Hello, everyone. I am welcome to the ISPRM International Rehabilitation Week 2021, and I am Dr. Muhammad Tawab Khalil, President, Physical Medicine and Rehabilitation from Pakistan, and I welcome you all to the third day, the physician session of the ISPRM 2021.
Hello, I am Sadatu Abubakar Mewada from Nigeria, Bayero University, Kano. You're welcome to ISPRM International Week. Thank you.
So we will be the moderators for today's session, and we are supported by ISPRM office as hosts Jessica Idley and Nicole Carducci. So additional files for today's session are available on the handout section, which you can find near the chat, and you can download any additional files if you want to. So please, and if you want to ask a question from the speakers or if you need any kind of assistance. So all the sessions will be recorded and you will be notified once the material is available for you to access. So let's kick off this event with a message from the ISPRM Rehab Week organizing committee member, Dr. Vanessa Tejas, introducing our daily or program for today.
Welcome to the second edition of the ISPRM International Rehabilitation Week 2021. My name is Vanessa Seijas. I'm a PRM physician from Colombia and currently working at the University of Lucerne and in the Swiss Paraplegic Research. Today's session will be mostly scientific and will be focused on PRM physicians as main target audience. We will learn more from our speakers about rehabilitation for healthy aging. Among the sessions for today, we will talk about assistive technology, osteoporosis prevention, healthy aging in individuals with cerebral palsy, and fatigue management. I hope you will enjoy our session and ask questions to our speakers via the Q&A session. Remember to write, where are you from? Thanks and enjoy.
So let's start our first session today with assistive technologies in rehabilitation for healthy aging. And Professor Rory Cooper and Professor Abdurrazak Hoiji will be sharing their views regarding it. So it is going to be a very interesting session as Professor Cooper will cover the topic in regards with the high-income countries, and Professor Abdurrazak will give us the perspectives of middle and lower middle-income countries. So just before we begin, I would just like to briefly introduce our speakers. So Professor Cooper is founding director and VA senior research career scientist of the Human Engineering Research Laboratories at VA Center in partnership with University of Pittsburgh. Professor Cooper is an adjunct professor of Carnegie Mellon University and of the Uniformed Services University of Health Sciences, and he was awarded honorary doctorate by Jian Zedong University. Professor Cooper has authored and co-authored more than 375 peer-reviewed journal publications, and he has over 30 patents to his name. So Professor Cooper is also an author of 2 books, Rehabilitation Engineering, Applied to Mobility and Manipulation, and Wheelchair Selection and Configuration, and co-editor of 4 additional books. In 2013, Professor Cooper was awarded with the International Paralympic Scientific Achievement Award, and he serves on National Board of Directors of Easter Seals and board member of the U.S. Intellectual Property Association. In 2019, Professor Cooper was revealed as the 28th inventor in the U.S. Patent and Trademark Office Inventor Collectible Card Series. Dr. Cooper's highest awards include the Sigma G. McGovern Medal for Science in Service to Humanity, Samuel E. Heyman Service to America Medal, Secretary of Defense Meritorious Civilian Service Medal, AAS Mentor Award, Joseph F. Engelberger Award, Olin E. Teague Award, Chapel of Four Chaplains, Legion of Honor, and inaugural class of the Spinal Cord Injury Hall of Fame. Professor Abdulrazak Hoji is a full professor and head of Physical and Rehabilitation Medicine Department at the University of Sidi Mohammed bin Abdullah of Fez in Morocco. He was graduated as a PRM specialist in 2009 and pain specialist in 2012. Professor Huji is the author of several peer-reviewed journal articles, and he has given several conferences in his areas of expertise all around the world. In 2019, he published a book on stroke rehabilitation in adults. Professor Abdul Razak is an expert consult to Moroccan ministries, public establishments, WHO, UNFPA, Humanity and Inclusion, and NGOs. He is an active member of ISPRM and is involved in several of its committees and working groups. He is also an active member of ISCOS, elected president and vice president of the MENA Spinal Cord Injury Network, member of the African Spinal Cord Injury Network, and founding president of the Moroccan Society for the Promotion of Rehabilitation Sciences and Disability Prevention. So let's watch their presentations on assistive technologies in rehabilitation and healthy aging.
Hello, I'm Rory Cooper, and I'm going to be talking to you today about assistive technologies for rehabilitation and healthy aging. First, I'd like to point out that assistive technology is extremely important for healthy aging among people with disabilities, as well as our older adults who may acquire disabilities as they age. One thing that's very important is to listen with people with disabilities themselves. We do that frequently with our voice of the consumer studies, as well as focus groups, mapping of people's activities, daily living, and integrating people with disabilities on our research team. Let's talk about secondary condition prevention. So first, for wheelchair users, wheelchair quality is extremely important for reducing the risk of injury. Such things as we have done the Meyer-Kaplan survival curve analysis by purchasing wheelchairs and testing to wheelchair standards. The vertical line you see on my screen, highlighted by the arrow, shows where all wheelchairs should last. As you can see, some of them don't do so well. Others, typically the ultralight aluminum wheelchairs, tend to fare reasonably well. Illustrated here on the left are some of the tests, and then up on the upper right, you can see some of the failure mechanisms. One way to help improve comfort and reduce the long-term injury to wheelchair users, and also durability without increasing a lot of weight, is by adding suspension. So on the upper right, you can see in-wheel suspension systems that are commercially available and are being tested to show if they help reduce neck and back pain and other injuries that may recur. And then in the lower left, that's the image of the glide caster fork that was invented in the Human Engineering Research Laboratories. A lot of the shock and absorption comes through the front casters. One, because people drive forward most of the time and the casters are smaller and more susceptible to bumps. The smart wheel is an invention that led to reducing rotator cuff injuries, as you can see where my arrow is pointing on the biceps tendon, as well as carpal tunnel injuries. Here's the median nerve compression. You can see this with ultrasound images. The smart wheel is a tool that we developed to measure the push-rim forces and moments, and that resulted in ergonomic push rims, as well as the path lock, which is a locking device to help reduce the strain on the upper extremities as well. WheelFit is an app developed by our colleague Dan Ding and her students to help provide fitness guidelines and caloric expenditure guidelines for individuals who use wheelchairs. The virtual seating coach was developed basically in order to meet the clinical need that we had identified of people getting power wheelchairs with power seat functions, but their condition not improving. And so we did a series of experiments to identify that people would use their power seat functions, but not necessarily as instructed. The idea with the virtual seating coach was to use the advances in technology, but first onboard computing, later use the technology interacting with the user to help the user get the maximum benefit from the technology they're using. There's also advances in home and community care, smart homes, and with you can use both commercial devices and specialized devices to improve living at home and also exporting rehabilitation to the home.
Even in the kitchen, where something as simple as preparing meals can be a real challenge.
This kitchen is designed for people with Alzheimer's and brain injury.
This is the queuing kitchen, where specially designed computer programs provide cues or step-by-step instructions for cooking things like pasta.
When I click next, the program will give me my first instruction on how do I get started with making pasta.
Take out cooking pot from the lighted cabinet. Take out pasta from the transparent cabinet. Fill the cooking pot with water from the water faucet. Turn the faucet off.
And then on transfer devices, robotic devices are now have the capability to help people with doing transfers without the use of a sling or without having to lift people. Here you can see the bed comes up to work as the serve as a backrest, and as the wheelchair backrest gets out of the way. And there's a conveyor on the belt that helps to move the person from the wheelchair. As you see now, the seat on the wheelchair moves back to fill the gap and tilts as the back bed builds. And then the person could use the conveyor to reposition themselves as well if they slide down in bed. But this reduces the strain on both individuals with disabilities and caregivers. Promotes healthy aging for both, especially helping individuals get in and out of bed more frequently. So this showing some activities that people, if they have a properly fitted wheelchair, what they can do. Here climbing a steep ramp, or we're even going to show going down a small set of steps using the handrail. Or going over uneven surfaces, such as sand and gravel. So type of wheelchair and properly fitting wheelchair are critically important.
Hi, my name is Joshua Zhong. I am a researcher at the Human Engineering Research Labs. My research project is focused on the performance evaluation and the user interface of the assistive robotic manipulators. So the assistive robotic arms is that a robotic arm can be mounted on the wheelchairs, and that can assist wheelchair users or people with the disability to do some daily tasks using the control interface. So the reason.
And then also to get out about in the home and community and provide safety, there's devices such as the strong arm that can assist with lifting. It's essentially a lift device mounted to the wheelchair, can be left or right, and reduces the strain both on individuals and caregivers. There's such devices as the iBot that promote stair climbing, curb climbing, and eye-level communication. And devices such as the MeBot, which you can see an individual with a high spinal cord injury being able to climb a large 8-inch curve. And as you see, as he descends the curve, and you can see ascending on the left and descending on the right, also have an eye-level conversation with individuals. And this capability, if you look on the pictures on the lower part of the screen, also has the ability to level side to side, so you reduce the risks of tips and falls.
So how do you build a water park that all kids can enjoy? That's the question Gordon Hartman had. He runs the world's first accessible theme park, Morgan's Wonderland in San Antonio.
We had to come up with a wheelchair that would allow for it to get wet and still be able to move about through the use of someone's ability to use a joystick.
That's when he discovered the work of Dr. Rory Cooper at the University of Pittsburgh School of Health and Rehabilitation Sciences. Dr. Cooper is world-renowned for numerous patents and inventions. Their team works out of the Human Engineering Research Laboratories, where they modeled and built the new chair. The chair that makes a challenging trip to the water park, well, fun.
I like to have the freedom to run around.
It was rewarding to see just how he lit up and the enjoyment that he got out of going through the sprinklers and the water.
He wants to be independent. Quite frankly, we let him go for 30 minutes by himself.
And then also transportation is key to for people's health, well-being, and participation in society, and is currently a tremendous problem worldwide. Hopefully with autonomous vehicles and smarter vehicles, we'll make that more accessible for people with disabilities. Sports and recreation are also important for maintaining health, both winter sports and summer sports, as we've seen illustrated here with Nordic skiing and hockey, but there are, of course, a whole range of sports that people can participate in, as well as summer sports such as tennis and cycling and hand cycling. So thank you for this opportunity. I enjoyed speaking with you today.
Good morning, good afternoon, and good evening. My name is Abdelrazak Hajiwi from Morocco. I am professor of physical and rehabilitation medicine at the University of Fez. I would like to thank the organizing and scientific committees for the huge effort that have done to prepare the ISPRM International Rehabilitation Week 2021, with focus on the topic rehabilitation for healthy aging. Very excited to be given this opportunity to present a fundamental topic in rehabilitation for healthy aging through my conference on assistive technologies in rehabilitation for healthy aging. Before starting my presentation, I have no conflicts of interest regarding this conference. Learning objectives of my conference can be summarized in 3 parts. The first learning objective is to know the current and future needs in assistive technologies in rehabilitation for healthy aging in the world, and in particular in low and middle income countries. The second learning objective is to identify the obstacles that limit and reduce access to assistive technologies in rehabilitation for healthy aging. And the final learning objective of this conference is to present solutions to improve access to assistive technologies for healthy aging. Who needs assistive technology? According to WHO definition, assistive technology devices are any item, piece of equipment or product system, whether acquired, commercially modified, or customized, that is used to maintain or to improve an individual's functioning and independence, to facilitate participation, and to enhance overall well-being. The list of priority assistance products published by WHO in 2016 clearly answers this question: who can benefit from assistive technology? As you can see in this figure, the people who most need assistive technology include older people. This assistive technology devices help older adults perform difficult daily tasks and activities. Assistive technologies are essential tools to prevent older adults from having to give up activities they enjoy. Assistive products can also help to reduce the need for formal health and support services, long-term care, and the work of caregivers. Without assistive technologies, people may suffer exclusion, are at risk of isolation and poverty, and may become a burden to their family and on society. The need and unmet needs for assistive technologies is increasing, and the WHO estimates that over 1 billion people need one or more assistive products. The majority of these are older people and people with disabilities. As people age, including those with disabilities, their function declines in multiple areas, and their need for assistive products increases accordingly. As the global population progressively ages and prevalence of non-communicable disease rises, the number of people needing assistive products is projected to increase to beyond 2 billion by 2050. The need and unmet needs for assistive technologies is increasing because the demand for in-home healthcare growing exponentially. 9 in 10 adults plan to continue living in their current home over the next 5 to 10 years. The need and unmet needs of assistive technologies for healthy aging are increasing because the prevalence of disability increases with the aging of the population. More than 46% of older persons worldwide have disabilities, and more than 250 million older people experience moderate to severe disability. Looking ahead, the global trends in aging population and the high risk of disability in older people are likely to lead to further increase in the population affected by disability. The WHO Active Aging Framework calls on policymakers, service providers, non-governmental organizations, and civil society to take action in 3 areas or pillars: participation, health, and security. And assistive products enable people to live healthy, productive, independent, and dignified lives, to participate in education, the labor market, and civic life in complete safety. In all countries, and in developing countries in particular, measures to help older people remain healthy and active are a necessity, not a luxury. Here in this slide, you can see the interactions of ICF components for healthy aging. Assistive technology are essential tools to prevent older adults from the loss of functions. These assistive technologies help older adults perform difficult daily tasks and activities and to participate in civic life in complete safety. Assistive products can also help to reduce environmental barriers. Without assistive products, people may suffer exclusion, are at risk of isolation and poverty, and many become a burden to their family and on society. The positive impact of assistive products goes far beyond improving the health and well-being of older adults and their families. There are also socio-economic benefits to be gained by virtue of reduced direct health and welfare costs, and by enabling a more productive labor force and directly stimulating economic growth. As mandated by the United Nations Convention on the Rights of Persons with Disabilities, we need to improve access to assistive technologies in rehabilitation for healthy aging and an affordable cost, and at an affordable cost, and to foster international cooperation in order to achieve this goal. Promoting access to assistive products need to be an integrated part of universal health coverage, which is central to achieve the sustainable developmental goals, and especially the goal number 3, ensure healthy lives and promote well-being for all at all ages. Key opportunities for action on trajectory of functional ability and intrinsic capacity across the life course are shown in this figure. This figure identifies 3 subpopulations of older people: those with relatively high and stable capacity, those with decreasing capacity, and those with substantial losses of capacity. These subgroups are not rigid, nor do they cover the course of every older person's life. However, if the needs of these population subgroups are addressed, most older people will find their functional ability enhanced. Today, even before the predicted steep increases in need for assistive products are established, only around 10% of those in need have access to them. This is due to high costs, limited availability, and inadequate financing in many settings, as well as widespread lack of awareness and suitable trained personnel. In 2011, the World Report on Disability collated evidence for the global unmet need for assistive products of all kinds. We now know that many people have little or no access to basic assistive products, even in some high-income countries. Today, few countries have national assistive technology policies or programs. As a result, access to assistive products is far from universal. The majority are left behind. In many countries, access to assistive products in the public sector is particularly poor or non-existent, leading to high out-of-pocket payments that are a burden for users and their families. People from the poorer sectors of society frequently rely on donations or charitable services, which often focus on provision of large quantity of substandard or used products. They are often not appropriate for the user or the context, and many even cause secondary health complications or premature deaths. Similar scenarios are common in emergency response programs, where the need for assistive products is high, but often neglected. Factors contributing to the challenge of enhancing equitable access to assistive technology around the world. The many different definitions for assistive technology can lead to confusion about what they are and what is covered. The technology is changing rapidly. Complicated access to assistive technologies, system-level factors can make it complicated to access to assistive technologies, and the need for assistive technologies is increasing. Improving access to assistive technology required a people-centered assistive technology ecosystem. An overreaching policy is crucial across all proposed areas, supported by a comprehensive data collection and effective financing mechanism. Effective leadership and governance through national assistive technology policies ensure an adequate supply of quality, affordable products, and appropriately trained personnel for effective service provision. Despite all the weakness of the health systems and the obstacles that limit access to assistive technology in rehabilitation for healthy aging. Today, we have several opportunities that must be seized to improve access to assistive technologies for all at all ages. I present here some major opportunities such as the WHO Rehabilitation 2030 initiative, universal health coverage, and the decade of healthy aging 2020-2030. Promoting and protecting the rights and dignity of older persons and facilitating their full participation in society is an integrated part of the pursuit of the 2030 Agenda for Sustainable Development, which pledged that no one will be left behind. The Sustainable Development Goals of the 2030 Agenda make explicit reference to older persons and persons with disabilities with regard to ending poverty, good health and well-being, decent work and economic growth, and sustainable cities and communities, and sustainable development well. In conclusion, I believe that it's time to end the global neglect of rehabilitation, and the access to assistive technology is a fundamental right, human right, and the need is increasing fast as populations age globally. Improving access to assistive technology for everyone and everywhere. At the end of my talk, I can see that population aging is first and foremost a success story for public health policies as well as social and economic development. Looking forward to meet you all in person at the next ISPRM World Congress in Lisbon 2022. Thank you so much for your attention, and your questions and comments are welcome.
Any question?
Okay, yeah. Dr. Maiwada, I have a question.
Okay, you have a question?
Professor Cooper. So, Professor Cooper, it was an amazing talk, and we just got a sneak peek that how independent we can make our patients in terms of ADLs and community reintegration with the assistive devices. So definitely we have got a lot of food for thought from your today's lecture. So I would actually ask from you that can you kindly elaborate on the weight limit of the patient that can use iBot, which you have mentioned in your presentation?
Prof. Cooper?
Okay, I think we are having some sort of connection problem with the Cooper
there
right
we go.
now.
I can speak now. Yeah, the organizers had me muted, so thank you very much for that question. The weight limit for the iBot is 250 pounds, which is about 120 kilograms, which is about the standard weight limit for most wheelchairs.
Yeah, that is great.
Any more question? Okay, please, may I ask my own question, Prof. Cooper?
Yes, Dr. Maiwada, you can.
Okay, please, how can we take care of the musculoskeletal problem faced when using assistive devices?
That's a great question. I think there's two ways. I think people need to actively participate in exercise. hopefully under the guidance of a physician and a physical therapist and a recreational therapist if they're available. I think that actually promoting healthy exercise should be incorporated in everybody's lifestyle, but particularly people with disabilities and all of us as we're aging. And so I think the challenge actually is, and there's actually very simple ways to participate in exercise. You can do isometric exercise. You can push your own wheelchair. You can use simple things like inner tubes or even bottles of water or buckets of water if you're stronger for lifting. So I think there's, but I think the idea is that you should have a daily exercise routine as well as a stretching routine. One in order to maintain flexibility as well as maintain both physical strength and cardiovascular strength. I also think that one thing we should not overlook with exercise in sports is the psychological and social benefits as well. That, participating with other people, learning from other people, and also demonstrating to communities the contributions that people with disabilities can make.
Thank you. Dr. Tawab, any question?
Yes, Professor Cooper, I have another question for you. So you had briefly touched the robotic arm for the wheelchair. So can you elaborate a little bit further so as to what functions can be performed by the robotic arm and how does actually the patient control it?
That's a great question. So the robotic arm can actually perform a wide variety of tasks, such as opening doors, but probably the ones that most people most commonly use are for doing activities around the house, being able to pick up a book or a tablet to operate it, or to eat, or grab food or prepare food. So for example, when we take something out of the refrigerator and put it in a microwave, or heat it in a small like toaster oven, and then eat with it. And the benefit there is that it gives people great autonomy and spontaneity in their life, which is often missing for people with disabilities who depend upon other people. The nice thing is it can be controlled with a whole variety of different interfaces, from voice to a joystick to a tablet. So it can be used to accommodate people with a wide variety of different types of disabilities.
Thank you, Professor Cooper. So my next question will be for Professor Hauji. So Dr. Melissa actually wants to ask you that what are the examples of assistive technology that older people need the most? And do you have any concrete suggestions regarding that?
Sorry, can you repeat the question, please?
Yes, Dr. Melissa wants to ask you that what are the examples of assistive technologies that are most required by the older people? And do you have any suggestions regarding that?
In our context, I think the most assistive technology needed by the older people is, for example, sunglasses for wheelchair, something that we use every day, and in general, it's low cost and it's can be found in any cities and any place. If we can say the list of priority assistive technology published by WHO, we can find limited articles that it should be accessible to all population, and it's around 50. And here we can find the robotic and high technology assistive technology.
Yes. So I just have a quick follow-up question. How can you like promote the access to assistive technology in case of low or middle income countries?
Sorry, how?
How can we promote the access to assistive technology in lower middle income countries?
I think we know to improve knowledge and to share information, because we have no program for medical doctor, we have no program for a health professional, and especially rehabilitation workforce. They don't have any information about what is assistive technology, and they don't believe that assistive technology is part of healthcare and part of rehabilitation. So I think we should start by sharing, by improving knowledge and of the workforce, the health workforce in general, and especially rehabilitation workforce. And we should include the assistive technology at the universal health coverage, because I have impairment of vision. So to participate, I need sunglasses. Sunglasses is my treatment to participate and to do my work like the other population. So it's my right to have assistive technologies, and in my case, it's sunglasses. And thank you for including this topic in this conference. I think this is a good way to share knowledge and to make advocacy to improve access to assistive technology in the around the world and in low and middle income countries.
Yeah, thank you, Professor Hadui. I also have another question. Okay, so I actually wanted to ask that finance is a big issue when it comes to prescribing assistive technologies for elderly people in lower middle income countries. As most of the time, either the patients cannot afford it, or the governments, they cannot afford to give the assistive technologies to the patient. So in your case in Morocco, so how have you people crossed this barrier of finance, and how have you increased the access of assistive technologies for your patients?
In Morocco, we have a Ministry of Welfare and the Ministry of Health, and also civic societies that they gave assistive technology to people who need this assistive technology, but only the low-cost assistive technology and the basic assistive technology. For example, they give the sunglasses and wheelchair, and even to prescribe wheelchair, it's a personal prescription. We need to identify for each person which kind of wheelchair they need. So we should do a lot of work to clarify this question, that assistive technology is not given without examination, without assessment, without evaluation and prescription. And we have a lot of work to do to improve the access to assistive technology with a good quality.
And preferably a team approach, right? Is that including the person themselves, their family, and various healthcare professionals, right? So that we can also, we should not look at technology in isolation. We need to look at their living conditions, their transportation, their family support, as well as their technology needs.
And access to technology is not only limited by financing. We conducted a study on spinal cord injury in Morocco, and we compared to the other population around the world, and we found that even people with money, they can't access to good health services, rehabilitation, and assistive technology. So environmental barrier, there is no only financing, but other barriers like culture, like education, like training.
Yeah, I totally agree with you, Professor Hajoui, because it's just not finance, it's about the culture, it's about access, it's like a multi-dimensional thing. So thank you so much, Professor Hajoui, and thank you so much, Professor Cooper, for joining us and enlightening us with your views regarding assistive technology.
Thank you.
Thank you.
Thank
for
you. I
including this
also
topic.
have a topic. I also have a question, if I may ask Prof. Abdulrazak. Please, I don't know these challenges that you've mentioned based on the cultural differences. How can people accept the new assistive technologies based on their cultural beliefs? How can we try and encourage them?
That's a great question. I think we need to, one is use other consumers to work with them, right? So that they understand from older person or person with disability to person with disability to understand the benefits. And then I think it needs to be, largely I think a challenge of informing people of the benefits of what's available, the resources and what the technology can do for them. And so I think, and I would say there was a question in the chat about how to access this, and the World Health Organization has the list of essential assistive technologies, which I think is a great starting point for low and middle income countries, for that matter, all countries, to look at what types of technologies should be provided. I would say that's a minimum list, but it's so having said that, pretty much everything on that list should become eventually available to people with disabilities and older adults.
I can add to the answer of my colleague Cooper that I think we can involve the national universities and the research team in the country to improve to improve the technology, to develop the low-cost technology, and to improve the access of assistive technologies to all the population. And we have a lot of things to use with low cost and high quality of assistive technologies.
Thank you very much.
I would also like to add, this is a perfect area for ISPRM to get involved in.
Yeah, that is true, Professor.
True. Thank you. It's really nice and wonderful meeting you, and we really appreciate all your presentations as well as the answers you gave us. Thank you very much. Thank you. Dr. Tawab, any more thing?
No, I think now we should proceed with our next lecture because we are getting a bit behind the time. So thank you so much, Professor. Thank you so much, Professor Cooper.
Thank you.
Bye. Thank you. So we are moving on to the next session today, which is osteoporosis. Sorry. Which is osteoporosis prevention. We have Prof. Giovanni from Italy. Giovanni is a full professor of physical medicine and rehabilitative medicine and chief of Department of Medical and Surgical Specialties and Dentistry of the University of Campania, Luigi Vervitelli. His research interest is in the field of musculoskeletal rehabilitation, particularly in metabolic bone disorders and pain management. He is an active member of the several national and international scientific societies. He is the member of the management committee of the Italian Society of Physical Medicine and Rehabilitation, the Italian Society of Neurorehabilitation, the Italian Society of Orthopedics and Traumatology, the Italian Society of Osteoporosis, Mineral Metabolism and Skeletal Diseases, and the Italian Group for the Study of Severe Osteoporosis. Moreover, he is a confounding partner and executive director of the Italian Society for the Unified and Interdisciplinary Management of Musculoskeletal Pain and Algodystrophy. He is author of several papers published on national and international journals. He is invited speaker to several national and international congress. Please, let's watch the presentation on osteoporosis prevention. Thank you.
Good morning, I'm Giovanni Iolasco, Professor of Physical Medicine and Rehabilitation at University Vanvitelli of Campania. This is my disclosures. The theme of my lecture is the prevention of osteoporosis. Over the next 15 minutes, I will concentrate on just a few aspects of this complex topic. I begin by underlining that this complexity already resides in the definition of the term prevention, by which in medicine we mean all the actions taken with a view to reduce the risk of contracting a disease or to reduce its clinical consequences. In fact, we recognize several levels of prevention. Primordial, which refers to all actions already implemented in the early stage of life, aimed at reducing the development of risk factors for a disease. Primary prevention aimed at reducing the risk factor already present or improving the body's resistance to disease. Secondary prevention in order to reduce the complication of an already present disease. Tertiary prevention to reduce disability and mortality, and quaternary prevention for limiting the effects of excessive or unnecessary therapy. In osteoporosis, on the other hand, the term primary prevention improperly refers to intervention aimed at reducing the risk of the first fractures, while the secondary prevention aims to decrease the risk of new fragility fractures in an already fractured patient. It's thus clear that the target of osteoporosis prevention is to reduce the risk of a fragility fracture, distinguishing both a clinical fragility that leads above all to a greater risk of falling and a bone fragility that reduces the risk mechanical strength of the bone. But why does a bone break? The bone breaks when the ratio between the load applied to it and the capacity of resistance to the load itself exceeds 1. Consequently, from the biomechanical point of view, reducing the risk of fragility fractures means lowering this ratio below unity, which can be achieved either by decreasing the numerator, that is, by reducing the mechanical load on the bone, or by increasing the strength of the bone. Nevertheless, how do we, for example, increase bone strength to mechanical loads? These listed are typical all the available factors, tools. First of all, the anti-osteoporotic drug therapy, then the correct nutritional approach and the eventual calcium vitamin D supplementation, and then physical activity and therapeutic exercise. There are many drugs that have been documented to be effective in the reduction of risk factor of fragility fracture. As you can see, some drugs are indicated in both primary and secondary prevention, such as bisphosphonates, while others should be administered only after the first fragility fracture occurs, therefore in secondary prevention. In particular, denosumab anabolic drugs such as teriparatide, or even the new anti-sclerostin antibody romosozumab, which is both antiresorptive and anabolic. Here we don't have the time necessary to examine the documented efficacy of these drugs, but we can briefly say that the use of both antiresorptives and anabolics increases bone strength and significantly reduces the risk of fragility fracture, even in a percentage greater than 50% in subjects treated compared to placebo, as reported by the registration study, which on the other hand led to the marketing authorization by both the American regulatory agency FDA and the European EMA. This slide shows the management algorithm of the patient suffering from osteoporosis, starting from the indication on what to do to identify the subject at risk, and I'm referring to the use of FRAX, or how to do primary prevention, essentially based on a correct nutritional approach and a possible calcium vitamin D supplementation. Continuing with the indication for the use of anti-osteoporotic drugs in patients at high risk of fracture, or in cases that they have already had a fragility fracture. As you can see, the algorithm indicates that anti-osteoporotic drugs should always be administered in the presence of an uncertained good level of calcium vitamin D intake, which must be preferentially nutritional, and only in the case of an ascertained deficit corrected with supplementation. As you can see in this meta-analysis, nutritional intake, if possible, it's always to be preferred because it's more effective in the increase the bone mass and reduce the risk of fracture. Calcium supplementation must therefore first be given through added foods or by calcium waters, and only in the case of an ascertained low level of nutritional intake established through the administration of dedicated questionnaires should it be given through the use of drugs trying to give low doses divided over the day. Vitamin D should also be given only if necessary, therefore with the serum levels of 20-dihydroxy vitamin D below 20 nanograms per milliliter, while in the very elderly or institutionalized patient, it can also be administered without first measuring the serum level, since it's believed that these patients are certainly already suffering from hypovitaminosis D. In such situation, it may be useful to rapidly restore serum levels through higher dose, both daily or refracted, weekly or monthly. For example, 50,000 international units per week for 8 weeks. While it should be remembered that the administration of bolus greater than 100,000 are not recommended because they could even increase the risk of fracture. Of course, especially in the elderly patient, inadequate nutritional protein intake is necessary for the health of the bone and the skeletal muscle, as well as that other micronutrients, even if not yet supported by consistent scientific evidence. Physical activity is basically considered a fundamental element for the overall good health of the body, and in particular of the musculoskeletal system. Scientific evidence has not yet shown incontrovertible certainty on the type and extent of physical activity to be used in the prevention of fragility fractures. However, we can say that in general, the strengthening exercise within a multimodal approach is effective on bone mass and in reducing the risk of fragility fractures. All this is also recently confirmed by some important clinical studies, such as this study by Waltman. On the other hand, physical activity is also crucial in increasing the peak bone mass, which is that bone stock that we will then spend in old age. Acquiring more bone during childhood and adolescence will reduce the risk of fracturing when we are elderly. The fracture risk can also be reduced by reducing the risk of falling, of course, or the damaging load that occurs on the bone at the time of the fall. In this slide, you can see all the intervention to be implemented to reach this target. This is the important field for the physiatrist in reducing the risk of falling, who has always see, first of all, at the research of the factors that increase the risk of falling. Once identified what to correct, the physiatrist will proceed to implement a specific program. Here you see an example. In this slide, demonstrated how the presence of hip extension deficit induces a significant increase in the risk of falling in elderly patients. Therefore, recovering adequate hip extension is a goal of rehabilitation through, for example, stretching technique that can reduce the risk of falling and thus of fracturing the hip. It should be emphasized that very often the rehabilitation intervention is included within a multimodal approach. However, we must underline that even for physical exercise, we still don't have agreement in terms of evidence-based medicine in favor of their effectiveness in reducing the risk of falling, as suggested by this Cochrane systematic review on intervention that can be carried out in institutionalized elderly patient. On the contrary, this further systematic review carried out by the US Preventive Service Task Force concludes that multifactorial intervention based mainly on therapeutic exercise have substantial beneficial effects on the risk of falling in elderly living in communities. Even in this very recent systematic review published in the Journal of American Geriatric Society confirms the real efficacy even of therapeutic exercise alone in reducing the rate of falls in elderly people living in the community. It's documented that elderly mainly fall sidewise on the trochanteric region, therefore with direct damage to the hip in over 80% of cases. So the idea to reduce the damage with the use of pads that are able to attenuate the damaging mechanical forces causing hip fractures is applied in by the Finnish group of Pekka Kannus many years ago, 20 years ago, that used the trochanteric pads and demonstrated that these pads significantly reduce the risk of fracture in the institutionalized elderly. These data were recently confirmed by the review published on Osteoporosis International. In conclusion, we can say that the prevention of osteoporosis must be recommended for anyone and must first of all provide nutritional standards and adequate physical activity, as well as the elimination of risk factors that have been amended. Where necessary, and only in this case, the use of calcium and vitamin D supplements to be added to the diet may be indicated. Physical activity plays a role in improving bone mass, especially at the lumbar spine, but also at the hip, in particular with the strengthening exercise of a certain intensity and duration. For patients at greater risk, multimodal approach that includes both the use of drugs and non-pharmacological intervention, including therapeutic exercises, more effective in reducing the risk of the first fracture or the risk of further fracture in osteoporotic patients. Thank you for your attention.
Thank you so much, Professor Lolaskan, for your presentation. It was a very interesting and insightful lecture. And there is no doubt about it that osteoporosis is a very common and a silent but a deadly cause of morbidity in the aged people. And your lecture today will surely help us in our daily clinical practice. So I would actually like to welcome Professor Lolaskan and Professor Francesca Gimigliano, who is the current ISPRM President-elect. So we will now begin the Q&A session, and you are all invited to actually write your questions in the question section. And we have some questions from our audience. So Dr. Maiwada will, I think, ask the question from the speakers. Okay, so Dr. Chung Wai Lau has asked that, will you check the vitamin D level in all cases of fragility fractures when you work up for the osteoporosis, or just directly replace them with the vitamin D supplementation?
Hello, Mohamed. Nice to see you. We usually check every time.
Okay, great.
We don't just supplement it, but we always make the check before.
Okay, that's great. Dr. Sarah Mehran has asked that, what is the Italian system that is available to prevent fractures in the elderly population?
We don't have a special Italian system. I mean, it's so the issue is that we check people for the risk of falling, because falling is one of the main risk factors for having a fragility fracture, and so we prescribe strengthening and balancing exercises for people who are at risk of falling, and we prescribe anti-osteoporotic drugs for osteoporotic patients. So not just to prevent the falling, but also the fragility fracture.
Okay, great. Dr. Shiv Yadav is actually asking that, how will you identify the population that is at risk for fracture?
There is an instrument that it's also promoted by the WHO, that it's the FRAX instrument, and we usually use the FRAX instrument to set the threshold of people that should go under treatment, because this instrument of calculating risk calculates the risk for a fragility fracture in general, and in particular for a hip fracture. And as you know, Mohammed, the hip fracture, of course, is the worst case scenario of a patient with osteoporosis because it then requires a lot of expenses in terms of surgery and rehabilitation afterwards for its treatment.
Okay, great. So we are actually having quite a lot of questions from the audience, but unfortunately we do not have that much time. So we will actually post all the questions to the speaker via the email, and then we will notify all the people regarding the answers later on in the coming week. So thank you so much, Professor Francisca and Professor Lulascan. It was a very nice lecture, and thank you so much for answering all the questions.
Bye.
So moving on to the next session today, that is the healthy aging in individuals with cerebral palsy, which will be delivered by Professor Safa Mehran from Egypt. So Professor Mehran is a full professor of physical medicine, rheumatology, and rehabilitation at Assistive University, Egypt. She had her MD degree at 2005 from Assistive University, and she has worked as an associated professor in King Abdulaziz University, Jeddah, Saudi Arabia for almost 10 years, where she has developed the policy and procedures of the rehabilitation department and awarded for being an active member in the preparation process for getting the Canadian and JCI accreditations by the King Abdulaziz University Hospital. So currently she is working on her researches and participates in the education process of the residents and junior staff in the rheumatology and rehabilitation department at the AUM. So her special interests include musculoskeletal ultrasound and musculoskeletal medicine, neurorehabilitation, and osteoporosis. She has had many multiple international publications in the field of her specialty. She is an associate editor of the Journal of Orthopedics and Rehabilitation, TPQ Medicine, International Journal of Bone and Rheumatology Research, and Egyptian Rheumatology and Rehabilitation Journal. She is also a certified Provolone Academy peer reviewer and a member in the International Spinal Cord Society, Middle East North Africa Spinal Cord Disease Society, and the Egyptian Society of Rheumatology. So let's move forward and let's watch her presentation on healthy aging in individuals with cerebral palsy.
Good day, everybody. My talk today is about healthy aging in individuals with cerebral palsy. This is my disclosure, and this is the agenda. Transition to adulthood. CP patient is exposed to dynamic process of development and aging, despite being defined as a static motor impairment. Adults with CP need health services for the continued monitoring and management of their conditions. Furthermore, the development of additional health problems in adults increase the need for ongoing health access for health services. What about CP mortality and life expectancy? Two periods of lifespan need consideration when describing mortality among adults with CP. The first period is survival through infancy and childhood into adulthood, and the second is the survival within the adulthood period. Mortality in CP is highly concentrated in infancy, but such deaths are difficult to attribute firmly to CP. Number and severity of CP-associated disabilities have marked impact on survival to adulthood. Population of adults with CP will grow to include large number of more severely handicapped persons in the coming decades. Let's discuss the cardiopulmonary and metabolic morbidity. CP were found to carry a higher rate of chronic conditions such as diabetes, asthma, hypertension, other heart conditions, stroke, and emphysema than adults with CP. Age has been identified as the strongest independent predictor to vascular health. Annual checkups for such morbidities is recommended, and regular exercise is well known to prevent and control these conditions. Deterioration of physical activity. In adults with CP, physical activities were reported to decrease with both increasing the functional score level and aging. There is lack of evidence supporting the efficacy of intervention to sustain and increase habitual physical activities in children and youth with CP. Children are either born or acquire CP palsy in very young age, so they may be habituated with abnormal movement as being normal. Trying to teach them how to move normally will not be helpful because they will not feel comfort and they will move within the range of spastic muscles. Therefore, early intervention for spasticity in children with cerebral palsy is crucial. They have also many musculoskeletal issues. Osteoporosis and arthritis is among them. Adults with CP are more frequent deficient in vitamin D due to the use of anticonvulsants, fewer outdoor activities, limited weight bearing, inappropriate nutrition in adults, and others. All these factors represent potential risk factors for early onset of osteoporosis. More frequent checkups and activity intervention are acquired starting at young age. Evaluation of body composition using the DEXA or lean body mass is clinically important to optimize the function and to improve the feeding and exercise intervention. Interventions to increase weight bearing or muscle mass are preferred. Reducing the risk of fall in ambulatory individuals with CP is also important. The development of protocols for diagnosis and treatment of osteoporosis in individuals with CP is needed. Scoliosis is also encountered in about 60% of adults with CP. With the annual increase in the degree is about 1 degree of scoliosis increased every year. Progression can be accompanied with loss of function and pain, which when occurs associated with thoracolumbar soft tissue strain on the convex side and degenerative changes on the concave side. To solve this problem, custom molded seating or postural thoracolumbar orthosis can provide relief, along with other conservative measures such as episodes of physical therapy or non-steroidal drugs. Spondylolysis and spondylolisthesis are also problems. Spondylolisthesis occurs usually after the age of 6. Spondylolysis with fractures of the pars interarticularis usually results from the repeated hyperextension of the back. Hip dysplasia and displacement occurs in about 1% of patients with spastic hemiplegia, 5% in diplegia, in more than half patients of the quadriplegia. With pain and degenerative arthritis developed in about 50% of individuals with CP. Pain and osteoarthritic changes encountered in decreased the functional weight bearing and mobility and progresses with time. Early identification of hip dysplasia and intervention in young adults can interfere with the development of such morbidity. Intra-articular injection of long-acting corticosteroids together with anesthetic may provide pain relief for about 6 months. Total hip arthroplasties are indicated after failure of conservative treatment. The knee is also affected, especially with patella alta in patients with spastic diplegia and crouch gait. So every effort, either medical, surgical, or physiotherapy to decrease the crouch gait is mandatory. Maximizing the knee ankle foot extension couple along with the hamstring, quadriceps, and hip flexor stretching and strengthening muscle involved in weight bearing and gait. Stretching and tightness of the rectus femoris muscle is of a paramount importance. Sarcopenia is found in CP patients. They found that they carry a smaller psoas major and a smaller calf muscle denoting the presence of fatty infiltration and poor muscle quality. They show low basal metabolic rate despite being on a calorie controlled diet. Dietary modification with nutritional supplementation and exercise therapy are needed. Protein in diet together with muscle exercise, regular muscle exercise will increase the muscle power, decrease the muscle wasting, and improve the condition of the patient together with supplementation of about 800 international unit vitamin D daily. Pain is also encountered in several areas in CP patients, either in the cervical region, back area, muscles, joints. It may be due to contractures, orthopedic deformities, fracture, or pressure from sitting on bony prominences as well as the presence of spasticity. Thorough examination of this population for painful conditions together with early intervention to decrease their impact on the functional level of the patient is important. Myelopathy is also found in cervical area. Cervical myelopathy is often induced by early degenerative changes in the cervical spine, together with the abnormal movement of the patient in either dyskinetic or dystonic CP patient. Surgical intervention might be helpful, but the outcome is not favorable because of the persistence of the neck movement and after surgery. So serial MRI scan every 2 years is important to detect changes. Botulinum toxin injection help minimize the cervical dystonia, particularly excessive movement of extension and axial rotation. Medications to control the dystonia should be considered, and more calm environment together with stress reduction strategies are mandatory for these patients. Neurogenic bladder is also found in CP patients, mostly in the form of urgency and incontinence. Anticholinergic medications can help controlling this problem. For urinary retention secondary to detrusor sphincter dyssynergia, injection of botulinum toxin into the pelvic floor muscles relieve the hypertonicity and the outflow obstruction. Medical providers should ask more frequent questions regarding bladder dysfunction in individuals with CP across their lifespan. Nutritional challenges and dysphagia. Children with CP are reported to manifest with higher prevalence of dysphagia as provided by video fluoroscopic swallowing studies. Adults with CP, despite maintaining the same dietary pattern in their childhood, may experience gradual deterioration in their swallowing and mealtime capabilities. So follow-up with speech-language pathologists are mandatory to catch these cases and treat them early to avoid the sequelae of malnutrition. Functional limitation. The functional score level remains almost stable within the first 2 decades of their life. Deterioration starts in the late 20s and the early 30s. This decline may be due to medical age-related challenges in patients with CP. So if the GMFCS score deteriorated from level 1 to 3 to become 4 to 5 with age, it's likely that the adults with CP represent a burden to his family and family member, caregiver, and increase the need of assistive device. Therefore, functional limitation should be addressed in health policy registrations for adults with CP, regulations for adults with CP. And recently, they have been moved towards the development of an international classification of functioning disability and health guideline score set for adults with CP. Spasticity is also found in CP with adults in the adulthood. Botulinum toxin is a cornerstone in the treatment of spasticity in such population, especially in dystonic muscles. Adults with CP will benefit from intrathecal baclofen more commonly, but not exclusively those with non-ambulatory status. Gait aids might help the patient with spasticity. Careful monitoring with serial radiographs for the lumbar spine of these individuals early detects the allows early intervention. Surgical options include segmental fusion of the spine in such resistant cases, and efforts to minimize slow walking should be provided with the use of appropriate orthoses when indicated. Health-related quality of life and social participation. Communication problems are encountered in this population because of speech, language, and hearing impairment. These impairments are usually not addressed in the clinic. They may interfere with the employment abilities and involvement of the patients in their social community, and increase the sense of emotional well-being of this population. The best way to identify any comorbidity or any communication problem is to have regular speech, language, and hearing examination. Quality of life, this is what we are working on to improve in this population. Little is known about the quality of life in this population, and little is written in the literature. Review article in the quality of life of such patients have encountered 15 quality of life instruments involving specific and generic, among them the SF36 and the Euro Quality of Life 5D and the Nottingham Health Profile. More is needed about the examination of the quality and the investigation of the quality of life in such population and what affects them, either negatively or positively. Lastly, the take-home message. Adults with CP are living longer, associated with improvement in the medical and surgical care. With aging, many conditions develop that can result in pain and significant loss of function over time. Addressing an early correction of such conditions allow the CP adults to gain healthy aging process. Communication barriers and pain might not be recognized in by the busy clinician. Regular checkups and the involvement of regular exercise programs were reported to improve functional status, decrease the level of required assistance, and reduce the incidence of secondary conditions in this population. Thank you.
If I'm interested. Please, can we go to the questions? If there's any question.
Yes, I have one question for Professor Mehran. I would like to ask her that how often should you conduct a DEXA scan in adults with cerebral palsy?
Good evening or good afternoon, according to the place where you are. Thank you for the invitation to attend this fruitful meeting with this fruitful bunch of physical medicine and other specialty physicians. Actually, the transition to adulthood in the CP population, it doesn't take this much or needed interest from even our community as physiatrists. But after I made this lecture, I found that regular checkup for CP patient along his lifespan is mandatory. In our clinics, annually, biannually, or even each 2 years, it's enough to detect these cases and these problems early. Mostly, or most of the families accept that the condition of their children will not improve, and it's getting worse with time, and this is unavoidable. Education for the environment, education for the physicians to tell their mother that some changes will occur in your baby in his development time, and when he transitions from the childhood to adulthood, it should be monitored as regards the speech, language, urinary bladder, constipation, walking, even his physical function should be checked up regularly. Decreasing the cost of the visits to the mother and her family is mandatory for the regular checking in this population, because they suffered a lot since birth till the death of their child. Actually, in our community, we don't have this regulation, but who's interested should take care of his child. He should bring him to the doctor each year at least to check the condition, even he's not complaining from anything.
Thank you. We also have another question from Dr. Thuyan. What are the common causes of early death in adult CP patients?
Usually respiratory problem. Aspiration pneumonia is a common one because of the swallowing problems. Usually also we have encountered the increase in the cardiometabolic problems in such population. They might die from heart problems. That's not known because they are not complaining.
Thank you very much. This due to time factor, I think we are moving on to the next session. Thank you. We are really grateful. Bye.
Thank you.
Thank you. So to the next session today, we have fatigue management, which will be addressing lack of energy and drive in elderly, presented by Dr. Sarah Welsh. Dr. Sarah Welsh is an instructor in the Department of Physical Medicine and Rehabilitation, an Asheville VA Quality Scholar Fellow, a Vanderbilt MPH candidate, a member of the Rehabilitation Medicine Scientist Training Program. She graduated from Rutgers University with a BSc in Biology and a minor in Technical Writing. She then went on to work in regulatory management of clinical trials while receiving her MA in Clinical Investigation at Boston University. During medical school, Dr. Welch was awarded funding from the American Federation for Aging Research to study geriatric mobility decline and falls at Harvard Medical School. She completed residency in PM&R at Vanderbilt University Medical Center. Her clinical work is now focused on rehabilitation consulting in Vanderbilt, contracted schools, nursing facilities for patients with rehabilitation, and long-term care needs. Dr. Wells' research interests lie in geriatric rehabilitative care as it applies to acute care, post-acute care, and transition of care. She is passionate about delivering evidence-based practice to older adults and evaluating interventions that improve processes and patients' outcome. Please, let's watch the presentation on fatigue management, addressing lack of energy and drive in elderly. Thank you.
Hi everyone, my name is Sarah Welch. I am an instructor in the Department of Physical Medicine and Rehabilitation at Vanderbilt University Medical Center and a VA Quality Scholar in the Tennessee Valley Healthcare System, GREC. Today I'll be talking about fatigue management, addressing lack of energy and drive in older adults. First, we'll talk about etiology behind fatigue. Then we'll discuss non-pharmacologic management. And finally, in patients lacking kind of drive or motivation, providing goal concordant care. I have no disclosures or funding to report today. So why do we care about fatigue? The population prevalence rates are estimated around 15 to 29% in community dwelling older adults. This talk is not limited to community dwelling older adults alone. I suspect if we included institutionalized older adults, this number would be higher. It is known to impact normal functioning, physical activity, social participation, so it's important that we pay close attention to it. Also, there's no gold standard treatment for fatigue. It's likely caused from multifactorial reasons, and so there's a lot to consider and cover honestly during our 15-minute talk today. So first, infection. There are an exhaustive list of potential infections. We definitely don't have enough time to review all of those potential sources, but of note, COVID-19 has been reported in the literature as a recent important cause of fatigue for 60 days or more in the geriatric patient population. It's important to get a good history and physical exam on your on your patient, and vital signs to start, heart rate, temperature, things like that to consider, complete blood counts, plus or minus a differential, viral panel, chest x-ray, urinalysis. In this patient population in particular, we know we're more likely to see urinary tract infections manifest in sometimes unusual ways. So we keep that in mind. Metabolic causes, hypoglycemia, hyperglycemia, hypo or hypernatremia in the elderly can be indicators of other problems, and definitely associated with fatigue, as well as kidney or liver dysfunction with rising levels of electrolyte imbalances. And so getting metabolic panel is something that we typically always do. And anemia. Anemia is a known cause of fatigue. It's relatively easy to treat. We can check our B12 levels, as deficiency of that is a well-known cause of fatigue. Additionally, checking iron stores and other causes of anemia. Chronic illnesses in general are associated with fatigue, and we know that older patients get more heterogeneous as they age, with increasing numbers of chronic medical conditions. And so this kind of complicates the picture in our patients and the number of factors we need to consider when someone reports that they have fatigue. And so some of the most notably identified associations in the literature include sleep-related disorders, such as obstructive sleep apnea, or cancer-related fatigue, movement disorders such as Parkinson's, and neuromuscular myopathic disorders. Hypothyroidism and thyroid disorders in general are easy to work up with a blood draw, and so I typically always get that when a patient reports fatigue. Insomnia, so asking your patient about sleep. How many hours are they getting? Do they feel rested when they wake up? How many times are they going to the bathroom? Insomnia and sleep-related disorders are highly associated with fatigue. We will discuss sleep hygiene later. Keeping a sleep log can sometimes be helpful. And so these are all things you might want to think about. As far as depression and cognition goes, I'm not going to go into detail on these measures, but these are tools that I like to use, all quick and easy, relatively easy to implement. The PHQ-9 for depression, the BCAM for delirium, and the BIMS for mental status, cognitive impairment. All things that are really important to consider in patients with fatigue or motivation issues. So, and things that can be treated as well in some ways. And so polypharmacy is common in the elderly and is also highly associated with fatigue. It is the use of excessive or unnecessary medications. And so, although definitions do vary in the literature, generally speaking, greater than 5 medications is known to be associated with poor outcomes. As I'm mentioning polypharmacy, I also want to mention that pain is important. Pain can affect mood, fatigue, motivation, and so making sure that your patient's pain is managed is something you want to think about. And manage. And then finally, malnutrition and dehydration. Super common in the elderly. Unfortunately, we don't have a single test that we can order to kind of work this up. We can get some lab work. We know that vitamin D is associated with a deficiency in that is associated with fatigue. Metabolic panels can also help us deduce, things like dehydration. But as far as the diagnosis of malnutrition goes, the kind of consensus approach indicates that we are supposed to use kind of 2 factors. So one would be a phenotype criteria, so something like reduced muscle mass or a low BMI or weight loss, kind of a decrease in those things. And then one etiology criteria would be something like reduced food intake or indicators of malabsorption, things like that. So as rehabilitation healthcare providers, I also think these are things we probably think about, but we want to consider if our patient has chewing or swallowing impairment, or mobility considerations, if they have an impaired ability to get to the bathroom? Are they dehydrating themselves, or do they need assistance with feeding? So all things to think about. Protein calorie malnutrition is pretty specific to older adults. Our patients are often not getting enough protein, not getting enough calories, and those are things we also work up and consider in these patients. So finally, let's get to management. So some of those things that we just talked about, we can, treat the underlying cause if possible. So we talked about thyroid disorders or sleep disorders, and ways that we can treat that. But we're also going to talk about some of these non-pharmacologic approaches that can be taken. So we do like to think about environment and task modification, and there's some research that has been done on that. So you want to consider the energy expenditure of your patient and modify placement of items in their home. So home modifications have been studied and have been shown to have positive benefit and effects on caregivers as well as patients. So we know that caregivers and patients have a reduction in worry or strain, improvement in their quality of life, just from simply modifying the home and making their ability to get around a little bit easier. Also, you want to think about modifying their tasks. So you want to think about the patient's mobility level and their need for durable medical equipment. Which tasks can you consider modifying? So as an example, should they sit rather than stand while showering? Those sorts of things. Sleep hygiene. So it's important that I mention that as we age, we have an overall decrease in our quality and our duration of sleep. This is normal, relatively speaking. This is a part of an age-related change. And so managing your patient's expectations is important in this setting, because insomnia is a separate issue that is not necessarily part of the aging process and has been linked with loss of productivity, decreased quality of life, psychiatric disorders. And so as far as insomnia goes, there are studies that have kind of shown cognitive behavioral therapy to be an effective treatment modality, so that we don't need to be, using sleep medications. And so that's something I like to think about in patients who have actual insomnia. And then as far as sleep hygiene goes, sleep hygiene is important for everyone, and it can be different for everyone in terms of the specifics of how to implement it. And so some of the factors to consider I've listed in this slide. And then as far as nutrition goes, there were some really great guidelines published in 2019, the ISPRM guidelines. I've listed a reference at the bottom of this slide. But I think the most important thing that I can kind of highlight from those guidelines here is that you want to screen and assess your patient and individualize their goals, kind of related to their dietary intake and their kind of individualized nutrition care plan. It is an interdisciplinary team approach. We are used to this in rehab, right? All aspects of the patient, their physical, mental, social, all of those factors need to be considered, and what options we need to implement to ensure adequate dietary intake. So does the patient need help with feeding assistance, in addition to, tracking their supplements, offering snacks, providing counseling? That's really kind of, I think that's a good summary of what we want to think about with nutrition. This is a complex topic. As far as exercise goes, there are there's a fair amount of literature out there on exercise in kind of cancer-related fatigue or multiple sclerosis-related fatigue. Less so in our geriatric patients, specifically exercise for fatigue. Also, many of our trials do not target kind of therapy on fatigue specifically, or maybe don't use validated measures of fatigue kind of as an outcome measure. That being said, what we find is that a multi-component approach does seem to have the highest likelihood for reducing self-reported fatigue. So combining things like resistance training, endurance training, and balance training is the way to go. Some of our cancer literature shows, you know, other things to consider, like cognitive behavioral therapy with physical activity, yoga, Tai Chi. I listed a reference here for that. But generally speaking, for fatigue, we want to think about these sort of multi-component approaches. Finally, addressing lack of drive and motivation. So kind of want to think about this in our patients who maybe this isn't just a fatigue issue, but an actual, you know, motivation issue. And so initially kind of thinking about our underlying causes, we talked about the PHQ-9 for depression. So do we need to treat, you know, a mental health concern first? And then identifying what matters most to the patient. So this process takes time. Do they think there's a problem, or is it possible that maybe what matters to them is different than what I think, you know, matters? And so it's really important to spend time with patients doing this and identifying kind of a person-driven outcome, because patients are going to be more likely to make the greatest gains when their goals focus on activities that are meaningful to them. So I tend to use open-ended questions followed by narrowed questions. So examples of opening questions that are being studied more and more as useful for these sorts of things include, what does a good day look like for you? What needs to be in place for you to have a good day? Or is there anything in your life you'd like to change that could help you get closer to doing well? So studies more and more are getting away from end-of-life planning and focusing more on current life planning with quality-driven, goal-concordant care. So I always like to consider our taxonomy of what our patients' priorities fit into. And so I consider kind of 4 buckets: connecting, enjoying life, managing health, or functioning. This is a really great article recently published in the literature, the Journal of Applied Gerontology, identifying 8 categories in patients who had at least one ADL limitation. So this can kind of help you focus in on how to then set a goal with your patient. And so then you want to set a SMART goal. SMART goals are specific, measurable, achievable, relevant, and time limited. And you'll be able to check in with them about those goals to kind of help with some of these motivational issues. So our learning objectives were to kind of think about our etiologic considerations, our non-pharmacologic management plans, and our health priorities aligning goal concordant care. So thank you. I'm looking forward to answering questions and discussing this topic with everyone.
Thank you so much, Dr. Welch, for your presentation. Because when we were actually planning that what topics should be presented, so we all came up with the topic like of fatigue management, because it was a very common thing that we in a patient, but there is very little evidence regarding its management. And I think you have like summarized very beautifully regarding its etiology and assessments and how we can go about it with a patient. So I'm like really happy for that as well. So we have a question for you, Dr. Welch. Dr. Thuyawen has asked that some people recommend daytime napping to help manage fatigue. So will it affect nighttime sleep pattern?
So my understanding of the literature on this topic is that it's actually a little bit mixed. My impression is that most studies are showing that napping will have little effect on subsequent, the following night sleep quality or duration, kind of in the older adult patient population. That being said, there are some studies out there that have shown a negative impact, right? But generally speaking, my impression is that the answer is no. It won't have a significant impact on the following night's sleep. I'm sure there's a lot more work to be done in that area, though.
Yeah, exactly. So, Dr. Mayavada, do you have any question?
Yes, there's another question posted by Dr. Rabia. If the patient has sleep problem, how long before going to bed do you recommend exercising?
So my understanding as well, again, this is I'm not a sleep doctor myself, but kind of the principles that I apply with my patients, kind of based on my own reading, is not exercising later in the evening, not drinking caffeine and later in the evening. I don't have a hard and fast rule for the number of hours, but I think these sorts of sleep hygiene concerns are very individual, right? I might be able to have one patient who can exercise 3 hours before bed and still sleep fine, and another patient maybe can only exercise in the morning, and at 2 p.m. it might even affect their subsequent night's sleep. So I think there's probably a trial and error that really you kind of just need to work with your patient on. And again, so much of this I think is dialogue and listening to your patient, and working with them on it, and making sure that you're pairing up as a team with your patient with these sorts of complex problems. So
Professor Welch, during your presentation, you talked about some medicines which are associated with fatigue. So can you tell us some of the common medications which you have seen that have some effect on fatigue?
Sure. I mean, so generally speaking, I mean, there's obviously a lot. I'm going to be biased because I work in the clinical setting that I work in is kind of the skilled nursing facility setting, right? And so generally speaking, in this patient population, I would advise reviewing the Beers criteria, right, in terms of which medications are most likely to have adverse side effects in our patients. So specifically, if we are looking at some of the more behavioral related medicines, benzodiazepines, some of the pain medicines, some of the antipsychotics, things like that, epilepsy, anti-seizure medicines, that's kind of generally what I would say I'm seeing. But again, you can't go wrong with kind of reviewing, obviously, the side effects of the medicine specific to your patient, and specifically maybe the Beers criteria as well.
Thank you. So this will be the last question. So for malnutrition, you have mentioned that you would do some metabolic panel for it. So do you normally go for serum albumin, or there is something else that you like to do in your patient?
Yeah, like I said, malnutrition is also a really, really complex topic, but we know that it's just one factor that plays into a patient's overall presentation of fatigue. Here in the US, I feel like what I see in the skilled nursing facilities and clinically what I see is we do often order prealbumin, but technically speaking, if we review criteria for diagnosing malnutrition, like I said, it can't just be kind of rooted in one factor. I pay the closest attention truly to weight loss. If I have enough data points on, my patient's weights, I pay close attention to that, as well as food logs and how much they're really taking in. But prealbumin is something we can definitely consider as part of the overall picture.
Okay. Thank you so much, Professor Welch. It was really nice talking to you, and thank you so much for answering all our questions. So we will now kindly ask all our audience to just remain connected for a few more minutes to reply to our quick polls about your experience today.
Thank you all. We sincerely thank all the organizers. We thank all the speakers that participate in today's presentation. It's really a wonderful one. We thank you for joining us today and we look forward to seeing you tomorrow. Please remember to share us on social media with the hashtag ISPRM Rehab Week and check out the program available online. Thank you and bye.
Thank you so much, everyone. Bye.